Hello, everyone. Welcome to Medwest presents the first virtual town hall by Economic Times and on the world affected by one problem, Corona or COVID-19. Our lives have changed and we all have many questions now. How are we going to face the new normal? What is the new normal? Everyone talks about the new normal, but we need to understand what is going to be the new normal. What are the things that are going to change in our lives in the new normal? Join us in this journey as we try to get answers to some of the questions. Today, we have leading national and international experts across the globe who, as frontliners, daily are seeing patients. They understand COVID the best. They understand how our lives are going to change in various specialty. So the next 90 minutes, the most pressing questions in various specialties will be answered by these experts. Joining me in this is Dr. Hemant Thakur, India's leading cardiometabolic physician from Mumbai. Dr. Hemant Thakur.
To everyone, and maybe good afternoon in Europe and the other places. We're living in a once in a lifetime moment, and I'm hoping it's once in a lifetime. Am I audible?
Yes, yes.
I hope we are living only once in a lifetime because there should be no other pandemic. We know that the sun rises in the east and brings all the brightness from the east, and the whole world follows. But this time in 2020, the east brought in darkness. And this darkness of gray has spread all through the world. And we are seeing different shades of gray. To say 20 times shades of gray may be true. But nothing is as constant as change. And we are human beings. We have fought and survived Charles Darwin's theory of where fitness and survival of the fitness is something which is the most important of the lot. Today, I have a galaxy of panelists from all over the world. I believe that at the end of this, we are going to emerge better, stronger, and definitely more planned, because what the classroom today virtually, which we are having, will help us to program and efface all that we knew. It will surface all that we have learned in the last 3-4 months and probably replace what we have to do for the next years to come as far as community is concerned, clinical practice is concerned, and everything else. I think so much for introductions. I'm going to begin my first panelist, a respected Padma Shri cardiologist, the senior most in the country, Dr. A.B. Mehta from Mumbai. Dr. Mehta, everybody knows Corona is a respiratory problem. I want you to tell us why Corona is as much a cardiac problem that you are seeing now.
Well, Hemant, good afternoon. Can you hear me clearly, Hemant?
Speak loudly.
Can you hear me clearly now?
Yes, better.
Okay. Um, the problem is that until now, anyone who walked into the emergency room area, I would consider an acute chest pain, as in all probability with the background of the risk factors and all. The first on top of my mind is to rule out acute coronary syndrome. But now a differential diagnosis is entered, and that patients with corona or COVID can also come with the cardiac manifestations due to myocarditis and inflammatory diseases. And so, therefore, this has impacted not only the diagnosis. On top of it, I also know that pre-existing coronary disease or pre-existing cardiac disease can worsen by the presence of COVID-19. So that's a problem that now we are facing. And we know that the one who is positive is likely to learn a more, might run a more stormy course. That's issue.
So would you say that this coronary presentation that you are seeing is a primary presentation of coronary artery disease, or is this atypical because of all the cyclonic storms and the other microcirculatory problems with COVID?
Now, if is one very careful, if you're very careful and take a proper history, and then I think acute coronary syndrome would not be very, very difficult to differentiate from COVID 19. However, in case if there is a borderline issue, like both have elevated tropi, both may have an STT changes, both may have chest pain. So in that situation, I think sometimes it may be a diagnostic puzzle. And in that situation, I think we might depend on some more investigations like echocardiography. And if echocardiography shows a regional wall motion abnormality, I will be more leaning towards the diagnosis of acute coronary syndrome. Hemant.
Great. So thank you for that. I'm now going to move straight to the East Coast of America. Somebody who is at the forefront, Dr. Kusum Punjabi, is an emergency room physician. But despite all the night sweats and all the horrible toiling hours that she's put in, she's looking fresh early morning. Tell us something about your emergency room impressions and experiences.
A very good evening and good morning to everyone there. So the ER here in New Jersey, which is the second state compared to compared to New York, that has been hit really hard by COVID-19 in America, the situation is getting a little bit better now. I think Mumbai in India is where we were in March, right? So in March, for example, in a 12-hour shift, I would see about 60 to 70 patients, all with COVID-19. All patients had COVID-19, very severe pneumonias. They would come in with high fevers. Most of them we would try with, nasal cannula oxygen, then non-rebreather oxygen, and eventually we had to intubate. We were seeing 60 to 70 patients that were very sick. And also we had tents outside the ER where we would see patients just with high fever, with cough, but who had good pulse oximetry levels greater than 92% on room air that we would send back home. Those patients we weren't even testing. So 60 to 70 patients in the ER in a 12-hour shift, and about 60 to 70 patients in the tent who we were not testing for COVID-19 who would go home. That was the numbers we were seeing in March and April. Now the situation is such, we're talking about May 15th, May 17th, right? The situation is such where we are seeing about 10 to 15 patients in the ER who are quite sick with COVID-19, and maybe 2 or 3 outside in the tent. So the numbers have come down drastically now in the United States. We're still seeing a lot of COVID-19 patients, but we're not seeing as much as we were seeing back in March, April.
God
now
bless.
what we're
Thank
seeing,
God.
yes. Now what we're seeing though is the complications of COVID-19. So as Dr. Mehta said, we're seeing the strokes because of the severe thrombosis that are caused in all the blood vessels, whether it's coronaries, whether it's cerebral arteries in the brain. So we're seeing strokes, we're seeing heart attacks, we're seeing a large number of patients with a lot of, ischemia, so blueness and blackness of the fingertips and the toes because of massive clots in the arterial vessels of the peripheral arterial vessels. So we are seeing a lot of limb ischemia, a lot of strokes, a lot of heart attacks, and now unfortunately, we are seeing a lot of children with the Kawasaki disease, myocarditis, very severe cardiogenic shock. And that's the presentations that we're seeing of COVID-19 now.
That's a very important point that she's brought out, and which is the message I want to give to all the physicians who are tuned in with us. When you discharge patients, and we are all discharging patients, even in Mumbai, happy and well, please put them either on a newer oral anticoagulant, or if not anything else, at least antiplatelet, at least for 6 weeks, so that we don't look at these problems. I'm sure Dr. Punjabi is also agreeing with that. We fortunately in Mumbai have numbers, but we do not have the tic-tac-toe dilemma, whom to intubate and whom not to. Either the Indians don't require intubation, or we have more ventilators, either because Trump has given us 200 or what have you, I don't know. But you mentioned something about Kawasaki's disease. And I have a pediatrician who's got her foot on the accelerator because she has a delivery round the corner this very minute. So before she goes away, and before she leaves, I want to invite Dr. Neeru Vithlani to tell me, but not so much about Kawasaki alone. I want you to tell me how you're going to advise the mothers who are tuned in now, how they should look after their kids and how they can come to your clinic. Dr. Vithlani. No, unmute yourself. Dr. Vithlani, unmute yourself. That's it. Unmute. No, that's it. That's it. That's it. Now go ahead.
Luckily, children have been less affected with COVID-19 compared to the adult population in the world. On an average, 1 to 2 or less than 5% in the whole world is the COVID population of children. And those children are also not really sick. You know, they've been tested because there's a family contact or an intrafamilial contact. So the children are tested, but they are asymptomatic completely. And even if they're symptomatic, they completely recover within 2 weeks without any treatment. But only 1% of population, few children get affected, children who are less than 1 year old and children who already have some pre-existing medical condition. And of late, there have been reports of Kawasaki disease and COVID-19 in children. There were lots of articles coming up in Lancet and from New England Journal, where the cases have been associated with a septic shock syndrome and atypical Kawasaki with COVID-19. Even these children, though they are affected, there's a large population, but luckily most of them are recovering very well and most of them are going home. So the mortality is not high. Below 10 years, there's no mortality. So Kawasaki is, but now what Bombay will see, there have been report of one case in Madras on 19th May, on 9th May in Times of India, a case from Madras with a similar episode. Now we have to see now after 4 weeks whether we will get a surge of Kawasaki, because that's what happened in Italy, that they had a big peak of the Kawasaki of the COVID-19, and after 4 weeks they started seeing the Kawasaki disease, which typically occurs as an antibody response. So in India, we are getting ready to be looking after 4 weeks what's going to happen to children in Bombay. On the whole, children have taken COVID-19 reasonably well. Why? We are under a lot of researches and studies are going on. The guidelines are changing, the disease is evolving, the understanding is evolving.
So that's very encouraging. Everything seems to be sequelae. As Dr. Punjabi and Dr. Mehta said, 3-4 weeks later, patients come in with the micro occlusions in the heart and in the brain, and you're talking about Kawasaki's disease after 4 weeks. So remember, the lockdown may end on day X, but you have to be careful for X plus 90 as the way goes along. Since you have to go away, I'm going to ask you your full set of questions. Would you like to say anything about bringing, well baby clinics that pediatricians have? Can kids be brought to the hospital for a checkup once the lockdown goes? Or what happens if they have missed their immunization schedule? That's something which is, people are asking us, so only you can tell us.
I think it's very important. When the lockdown occurred for 2 weeks, 3 weeks, we said, okay, let's wait. But since the lockdown had to be extended, seeing the clinical scenario, I think it is a duty of every doctor or every healthcare provider to encourage the routine normal checkup, especially newborn checkups, and to continue the immunization practice of the national policy of the country. Otherwise, if you disrupt this immunization schedule, we are going to get outbreaks of the other communicable disease, preventable diseases. So I think it's very important that every healthcare provider creates an environment of safety, an environment where children and parents can come one by one and create a place where there's a social distancing, there's hygiene, and there are rules followed, like every adult will wear a mask, the clinic staff will wear a mask, and teach them the guidelines and give them the protocols that these are the rules to be followed before you enter my office. And this is the way it's going to work. And we've been doing it for the last 5 weeks, and I think it's working out very well.
Thank you, Dr. Vithlani. COVID and God both are kind to the little ones
Yes,
amongst us.
thank you. I hope they are nice after 4 weeks too.
Yes, yes, they will continue
But
to be nice.
on the whole, even Kawasaki is not so common. It's not all that bad, and children respond beautifully to treatment.
And I shouldn't be saying, since we have a universal channel, but Kawasaki for India is more a disease of the western part of the world, maybe Africa also, not so much in India. So
No, but
let's hope.
we still
Yeah,
get it. Yeah.
we still get, right. So I think we now have to turn and sweeten the conversation a little bit, because we've been finding all our patients who are coming into ICU, they come in with high sugars. Everybody's talking about diabetes being a very big comorbidity. I have Dr. Bansi Sabu from Ahmedabad, who is one of India's foremost diabetologists. Dr. Sabu, would you like to tell us about hyperglycemia and COVID? Something unusual. Don't tell me that it's more common in diabetics. Something unusual, please. Dr. Sabu. Unmute yourself. Please
Yes,
unmute yourself.
I unmute already. Am I audible now?
Yes,
Thank you.
you are.
Yes. So I'm not going to routine thing. One very important thing we see COVID hyperglycemia. Again, there is one issue that in India, 50% of our patients of diabetes, even they don't know whether they have diabetes or not. So first time they might be detected during hospitalization. So when you have a new detected hyperglycemia in hospital, either a patient could have a pre-existing diabetes who is not been detected, or it is because of acute stress or a COVID hyperglycemia. So what we do is, if HbA1c is already high, then it could be a patient of pre-existing diabetes, but who was not detected because he has never tested for it. The other possibility is this patient whose HbA1c is normal and still the sugar reports are more than 180. It may be a patient of COVID hyperglycemia. There are some data in paper which had shown that because of COVID infection and there is inflammation, the pancreatic beta cells get dysfunction and they may have COVID hyperglycemia. We had seen some patients, because I am taking care of one of municipality hospital as a one of the consultant as a diabetologist, where we are seeing some of the patients who are getting admitted in ICU, sugar levels are very high. And in compared to the patients who have already pre-existing diabetes, the patients newly detected hyperglycemia or COVID hyperglycemia, they are more difficult to get under control. Even with the insulin dose, which goes as high as more than 100 units or even sometimes more than that, they are on IV insulin infusion every hour to check their sugar. Itself is a very difficult task for the even sisters to go and check their sugar continuously. We don't have any other way by which we can monitor and control these patients' sugar. Now, if you see the morbidity and mortality for these patients, instead of those who have pre-existing hyperglycemia or diabetes, rather the patients who are first time detected hyperglycemia in hospital or COVID hyperglycemia, the mortality is higher in those patients in compared to those who have pre-existing. And also there is some paper is coming directly, dose of insulin which is required to control these patients is also correlated with the morbidity and mortality of these patients too.
Absolutely. Very well said. Recent or immediate detection of hyperglycemia requiring higher doses of insulin denotes a recent new onset insulin resistance. And the prognosis in these people because of new onset insulin resistance is very bad and difficult to treat. So I think we have one more before we have a live absolute coronavirus on the show. I have one question for Dr. Gaurdas Chaudhary. Dr. Gaurdas Chaudhary is a gastroenterologist, and he's going to tell us about GI tract and the liver vis-a-vis COVID.
Thank you. In the initial part of our experience with COVID, and to be honest, COVID came as a surprise to all of us. So quite a few patients were actually complaining of nausea, vomiting, abdominal pain, and diarrhea. If you remember, Dr. Thakur, that was a time when many of the patients were also taking hydroxychloroquine and azithromycin because there were initial reports that they could help clear the virus. So our instinctive impulse was to say that this is probably related to the medications rather than to the disease.
Correct.
Later on, it appeared that quite a few people who did not take any of these medicines still had the problems. And then it became very clear that actually the GI tract is involved in about 20 to 50% of patients. So abdominal pain, nausea, vomiting, and diarrhea. What was even more interesting is that sequential studies done in many parts, including China, showed that after the virus had cleared from the throat and the nose, it still persisted in the stool and the rectum. And in fact, that raised a lot of concern as to whether the mode of transmission of the virus could be also fecal-oral rather than the aerosol-based, what we had been thinking about. And that has been a major concern of late. There has been a lot of write-ups now regarding toilet etiquettes and all that, which I presume we were doing anyway for cholera and hepatitis A and B, but now COVID becomes another indication. With regard to the liver, there has been spikes in liver transaminases that have been noted. To the best of my knowledge, there hasn't been any reports of liver failure, but high liver enzymes are part of the syndrome. And that's again something that has been taken very seriously by our hepatologists. So if you get these little events like, a spike in liver transaminases, diarrhea or whatever, don't let your vision or focus go off COVID. It is still COVID. If otherwise it is COVID.
Very, very nice. Here is a specialist who is telling you that though my specialty may show a blip, don't lose focus. Stay with the primary disease. So, Dr. Kaudri, I'm going to come back to you again on this, but we are about 20 minutes into the show, and I have a human specimen of the coronavirus with us. Dr. Chaturvedi is an ENT specialist in his own right, but I'm not going to ask him just now to talk about his ENT specialty. He's done such a fabulous job in his part-time occupation as a stand-up comedian that he has modeled his own self as the coronavirus. And that has come so closely for people to understand what it's about. Dr. Chaturvedi, the mic is yours, the camera is yours.
Thank you, sir. I do the Corona role in Hindi because the idea was to get this out to the wider audience in the rural areas. So that's why I could do a small bit to tell you.
Please show it to us. Please do it for us.
Yeah. So before the virus launched in India, I became Corona, and this is what I did. Hey, भाई लोग, मैं Corona virus है. लोग मेरे को बोलते थे कुछ Corona, तो मैंने अपना नाम ही Corona रख दिया है. और बोलते थे इधर क्या कर रहे है तू, वहां जा, तो मैं वहां चला गया, वो चाइना में है. फिर वहां से मैं इधर आया, वापस जाने को मत बोलना क्योंकि मैं बहुत डेंजरस वायरस है, मैं वर्ल्ड टूर पे निकला है. So with that, I was just trying to tell that the name and Wuhan, the place in China, and that I infect people. But also कि मैं ना उतना danger नहीं है, मैं topper नहीं है क्लास में कि 10% 15% mortality है, और मैं ऐसा भी नहीं है कि मैं common cold की तरह 1% से कम है. मैं average student है, 3 से 5% मेरा mortality rate रहता है. So to talk about the thing that it is a serious thing, but also probably not that serious as other epidemics that we've had. And so I've used this modality to get to a lot of people, and I don't know if it reached your WhatsApp messages, but these are short snippets.
You have something special for today, our virtual classroom, which you haven't done before.
Today, I can share some patient experiences that I'm getting because we run a helpline. And I think one of the things we may touch later on is the stigma that patients have. And nowadays, I get calls like this, Doctor Saab, actually, na, mere ko gale mein dard hai and nigalne mein dard hota hai. But it is the normal kind. It is not the COVID kind. And I have fever also, very high fever, but normal fever. I've been getting from many years. And, also a little bit of breathing difficulty, normal kind of breathing difficulty, as you get when you run. And I also, I'm having all of these body pains and aches, I think, because I was running around. And I'm saying, boss, you have almost all the symptoms of COVID-19. You should get yourself checked. Nahin, doctor sahab, normally hai, main bas koi dawai aap bata do. So that is something that we are seeing a lot. I'm not exaggerating this. I've got calls exactly like this.
You have hit the nail on the head. I look at the OPD in the morning, which I'm conducting, and out of 10 OPD patients in the hospital that I see, 6.5 or 7 are breathlessness of functional origin, who imagine that their throat is hurting. But I don't want to enlarge on it. I have with me Dr. Vihang Vaiya, who is one of India's foremost psychiatrists. So, Vihang Bhai, let's have your take on all this which is happening and which we just discussed. See what a wonderful picture we had of the coronavirus. So thank you, Dr. Chaturvedi. You're not going anywhere. I'm going to put you in every 20 minutes. So have a good stand-up act for me every 20 minutes. Dr. Vaiya, the floor is yours.
Thank you. Dr. Chaturvedi, I'm very impressed with what you said.
Thank you, sir.
We are 137 crore, 80 lakhs and some thousand Indians, of which approximately, say, let's get closer to 1 lakh are infected with coronavirus. 137 crores are not infected by the virus, but are petrified with the fear of the coronavirus. So we need to be sure to ensure our patients and people in general that coronavirus is an egoist. It will not enter your body unless you invite it. So the physical distancing and mask and the washing of hands. But then coronavirus also has a seed and soil mechanism. The seed is the corona and the soil is the human body and mind. Today, being petrified, feeling anxious and insecure is an obvious, common, anticipated response to these messages of coronavirus. What we need to make sure is that anxiety never lives in the present. It either goes into the past and makes you feel kind of guilty about wrongdoings or wrong decisions of the past, or it runs into the future and gives apprehensive expectations. We need to realize that we can neither change the past nor predict the future. We need to live in the now, today and now, live in the reality. Coronavirus is a reality, and to defend ourselves is the need. So keep our body and mind cool. If nothing, cold water mopping of the forehead, that itself helps. Mild physical exercise, rigid routine of lifestyle, including sleep-awake cycle, and the food habits are an absolute must. Dr. Thakkar referred to the Darwinian theory of evolution. What Darwin said is survival of the fittest. The fittest is not physically fit. Fittest are the ones who adapt themselves to the reality. We have to adapt ourselves to the reality, which is a disruption of our lifestyle. Our comfort zones are gone. Our habitual pattern of keeping ourselves relaxed are gone. We've got to explore our own potentials, learn new skills, keep ourselves physically active, and live in the present.
How wonderfully you put it. How wonderfully you put it. Indians are so keen to pat their friends on the back, to hug them. The physical expression of friendliness in India is enormous, and that has been taken away. Having said that, as you said, if we don't evolve, we don't adopt, and we don't adapt, we're going to get more patience for Dr. Vaiya. I'm going to now go far west and take you to the west coast of America. I have Dr. Henry Colt with us from the Irvine University, California, who besides being a pulmonologist has done a lot of work. And good morning to you. I know it's early morning, but you're looking brighter than the sunshine we have here right now. So can you tell me, I know you've done a lot of study in this pandemic about how doctors are being affected and, mentally, physically, whatever. Can you tell us a little bit of your experience?
Yes, well, we know that healthcare providers can be infected.
A little loudly, please. Loudly.
Yes. Is this a little bit better?
Yes.
Yes. We know that healthcare workers can be infected at the workplace, but we must not forget that they can also be infected while on transit, going from their homes to their jobs or at home, and certainly if they're not social distancing. So healthcare workers can be infected in many different circumstances. And we know that the transmission right now, we believe that the transmission of the virus is from respiratory droplet nuclei. So transmission can occur through large droplets, respirable droplets, and through contact with surfaces. And that is what we need to be able to avoid. The transmission rate, as we know, is 1 to 4 people and hopefully decreasing with social distancing. But the virus can be transmitted in asymptomatic people as well. So we need to really protect the healthcare worker. The healthcare worker can protect themselves by considering every patient as a potentially COVID positive patient.
Is there something you have as a message? Yes.
There is, and that is that we must remember that, like most viruses, the transmission is going to depend on the viral load, the frequency of contacts, the duration of those contacts, and therefore to decrease the rate of transmission, we need to protect ourselves by less frequent contacts, less contact with a viral load, and protection. And today the protection is really just mitigation and the clothing that can be worn. And one of the studies that we're doing globally has certainly shown that personal protective equipment works, N95 respirator masks work, and observers, someone who can help the healthcare worker respect the proper way of putting on and taking off protective personal equipment will help.
That's a very good point. You know, in hospitals where I work now, we've started a buddy system where each person has a buddy. So the buddy is supposed to help you and prompt you if you're making a mistake. Like you remove your footwear off first, then you remove your cap, and how you remove your other wear and touch the inner part, not the. So that's a great thing. Dr. Vaya and Dr. Chaturvedi both talked about mind over body, and especially in the lockdown, the mind over body. So what does the body do these days? All the time, the queues outside the snack shops, the food shops is phenomenal. And a lot of my people say we've become couch potatoes either because of the television or because of webinars like this. And, you know, when they become couch potatoes, they tuck in so much food. So therefore, I wanted one of India's best obesity specialists, Dr. Makkar, to be on our show. Dr. Makkar, good evening. Can you tell me whether COVID and obesity has any special relationship or a message for these obese COVIDians or to-be COVIDians?
Thank you, Hemant. Thanks for having me on the show. I think, it's very interesting. The problem in Indian setting is that we don't have much data on how COVID is affecting obese people and how obese people are faring with COVID if they are getting affected. But we certainly have data from a number of studies now that obese patients, they are being, they have a lower level of immunity, they have impaired immune system, and that's why they are more prone to get COVID infection. They are more prone to get more serious COVID infection. They are likely to have underlying comorbidities like heart disease, impaired lung function, and so on. And that's why they are more likely to get more complications, more hospitalization, not only just hospitalization, more prone to hospitalization in intensive care, and they have higher mortality. So I think all obese patients who in India, by convention, we think if somebody is overweight or obese is actually well off and is from a well-off family. But totally on the contrary, they are at a higher risk, and they have to be careful if they are getting infected. They have to prevent the infection by all means.
I think that's an excellent bit of advice. I'm going to come back to you for asking some more precautions later. But, we've been doing COVID all through long. I wrote an article 3 weeks ago saying, "Or diseases, thou art fled to brutish beasts. Where are all the other diseases going?" We've had nobody coming to hospital with hepatitis. We've had nobody coming with, strokes and things like that. But little did we realize that the neurologists of today who have been so busy are facing a very tough time. So I decided to rope in a dear colleague, Dr. Arun Shah from Reliance Hospital. Can you tell us something about what's happening to the COVID patients, to the non-COVID patients, especially when they get a stroke? How are we managing to look after them?
Yeah, Hemant, thank you for inviting me. I think there is a substantial collateral effect of COVID pandemic on other illnesses, particularly in relation to acute illnesses as well as chronic illnesses. And what we realize at our center, which is predominantly a non-COVID center, the stroke admissions have suddenly changed in the way that we are getting all severe strokes. And we are very early phase of COVID pandemic. And even in that phase, I am seeing substantially morbidity of stroke is much more than what I see usually in a year's time. So that is one point. And the reason for that seems to be that probably they are scared of coming to the hospital because they have phobia that they might get the infection. And second thing is there is probably a pathway which we had of stroke care has been interrupted because of the screening for COVID infection, whether he's infected or not. So that has substantially affected stroke care in our hospital. And similarly, in relation to chronic illnesses, such as, for example, people with seizure disorders, they have to have refill regularly. Fortunately, telemedicine has come to the rescue of that, and we are able to manage that. And finally, there are other chronic illnesses, neurological illnesses, such as multiple sclerosis or myasthenia gravis. They are on a lot of immunosuppressive therapy. So what is happening to them? And whether we should continue immunosuppressive therapy with them, and if they interrupt the therapy, their disease might worsen. And if we give them, they may have more severe COVID. So these are the dilemmas which neurologists faces as yet. Now, stroke, which has been described in relation to COVID, we have seen only once at the moment in our institution, though it has been described very often from USA, but as yet I have seen only one patient, but he had other comorbidities. So whether COVID was responsible for stroke, I'm not very sure. So that's what I think I want to give a message to all the people who are listening and physicians as well as this, that we are all geared up to stroke care and we have a different triage pathway for people with COVID and non-COVID illnesses. So don't be scared that you will get a COVID infection by going to the ER for your stroke treatment.
What a lovely message. Probably a stroke of luck for all the non-COVID neurological problems. From non-interventional medicine, I'm going to go back to the scalpel. We have Dr. Abhay Dalvi with us, a very renowned surgeon. Dr. Dalvi, you and I know each other for a long time. I want you to tell me how you surgeons are coping up with acute abdomens and acute surgical emergencies in these COVID times.
Yeah, good evening. Thank you, Hemant. I've been hearing this conversation from physicians. Surgeon is actually on a battlefield. Let me tell you that. And to prepare for this, I actually had to go back to my preventive and social medicine textbooks to understand what the surgeon feels in the era of COVID. As far as surgeon is concerned, a lot of social distancing is out because when we operate on a patient, all of us are near each other. So we have to be really ready for protection with a good quality PPE. So let me divide it into three things. Number one, for any calamity, we should have infrastructure to deal with it. You should have people to deal with it, and you should have equipment to deal with it. All three form important part of surgeon's life. Do we have the infrastructure in place as far as non-COVID surgery is concerned? We do have it, but we are in a dilemma whether every patient is going to be COVID positive or a COVID carrier. Then we come to the COVID positive ones. Do we have the infrastructure dedicated OT in place? As of in India, no. Because for operation theater, they advise what is known as negative pressure operation theater rather than the positive ones which are existent all over India. And that's why we have to work in a positive pressure environment and operate on such patients. And lastly, the equipment. You all know that a lot of equipment, instrumentation is required when we perform open or laparoscopic surgery. And all this obviously is not autoclavable, but has to be sanitized. So as a surgeon, there are a lot of dilemmas in front of us to go about and treat a suspicious or COVID positive patient. Can I have a little more time here?
You have another minute and a half.
Okay, fine, good, thanks. Now, let's say a patient comes in who I do not know whether he is COVID positive. I take him as a suspicious COVID positive, or I know that this patient is COVID positive. Luckily for us in Mumbai, we have COVID designated hospitals where the patient can be referred. But with increasing patient population in Mumbai, we now have COVID dedicated hospitals and non-ones also getting converted, like the institute that I am working in, the St. GS Medical College and KM Hospital. We have right now 389 patients who are admitted and waiting list of 75 patients who are high suspects. So this is the kind of load. Every day in an emergency situation, we are operating at least about 5 patients with minor or major surgeries. So a lot of exposure to these patients is taking place, considering that these could be COVID positive. 1 in every 5 patients that has been operated without RT-PCR or HRCT has turned positive in the post-operative period. So there is a lot of challenge as far as surgical branches are concerned, especially the general surgical branch, treating only emergency patients, elective as per government directives out. If you have to classify these patients, then you have what is known as a dire emergency, where a patient has to be operated as soon as the patient is admitted and resuscitated. This is an abdominal trauma patient, for example. Then you have patients who have to be operated within 6 and 8 hours, that is a peritonitis patient. And then you have a group of patients whom you can sit on till a testing is done. But the government, because of paucity of kits, etc., does not allow all patients to undergo this sort of a testing. And that's why we come into problem. So this is basically the situation, I would say, that comes into picture.
Very nicely said.
I will also talk on, if given a chance, lower down in the setup in India. Where
I'll come back to you again. But but the point that you have made is important, that acute surgical emergencies that need attention in less than 12 hours, you have to forget COVID. You have to think of health. A peritonitis, a gastric ulcer which has bled, which is ruptured, an appendicitis that has to be cholecystitis, that has to be seen, which brings us to the fact that sooner than later, hopefully we'll have a rapid antigen antibody test system, which will tell you in 20 minutes whether you can board the flight or you can't board the flight. We as physicians liken it to dengue. In dengue, if your IgM is positive, you have acute dengue. So from 7th day to 15th day, if your IgM is positive, you cannot board the flight because you could be having active corona. But if your IgG becomes positive after 24th day, the airline will welcome you with open arms. And if nothing is positive, you will not board because you don't want to go and get the corona. So we are hoping the surgeons also have this kind of. Now, before I get into this overdose of corona, I want to call my ENT stand-up comedian back again. Dr. Chaturvedi, ears, nose, and throat, I will leave you as a last question, but you have to lighten the moods of everybody, please.
Yes, sir. I think another thing that's happened now with the corona thing is a lot of telemedicine has happened, and sometimes that could be more troublesome than the virus itself. I had one of these incidences recently where there was this patient called Shweta who wanted an appointment with me at 7 o'clock. And then she wrote, "Doctor, can I postpone the appointment to 7:30? I'm like, "Sure, Shweta, you are my only patient for the last 1 week. If you say 7:30, we'll reschedule it." And she got so happy that she sent me 3 kiss emojis and 2 with the heart wala, on the face and all the smileys. I'm like, what did I write to her? And then I realized my over smartphone auto-corrected Shweta to sweetheart. And then I had a nightmare about a medical legal case about a doctor, doing something to the patient. And I immediately apologized. Sorry, it was a typo. It was an autocorrect. But then, these are the other things that happen, sir, when you are doing technology, and technology brings its own, issues with it.
I agree with you. You have some other incident to tell me? Please go ahead.
Yes, sir. I also have a lot of, one is a good thing, a lot of doctors are trying to invent, and I run a healthcare innovation company to help doctors. But sometimes I get a little amazing calls. I actually got one call from a doctor in somewhere in the rural parts of the India saying, "Sir, mere paas ek bahut acha idea. I have a very good idea and I want to sell it to you. Tell me how much will you buy it for?" I'm like, "You first tell me what the idea is, then I will tell you. But if I tell you the idea, then you will not buy it." I'm like, "If you don't tell me the idea, how will I know what it's worth?" And then somehow we explained the idea, and his idea was that a mask which has a flap in between, that whenever you want to speak, you can pull it out so that you are exposed, and then put it back in. And that was the idea, because according to him, the mask is to be worn only to survive the police and the other rules. but not really looking at the aspect of protecting the airway. So that was another thing that I saw over these times.
What you said is something which is medically very important. When a person speaks, the spouting of the virus, if he is positive, goes up to 4 to 5 feet. So remember, when you are talking, also ask him to wear his mask. You know, most of the time you meet the patient, the first thing is he takes his mask out and starts talking to you. No. Now, the only time you can remove your mask is if you are at home in your office alone, and that too, keep the mask facing down so you don't pick up anything else. I'm now going to come to a very sensitive mother and child issue. We did the child, but we haven't talked about the gynecologist who is dealing with 1.5 lives or 1.25 or 1.75 lives. What is the situation of pregnant women today? When they are either wanting to deliver, registering, or at the time of delivery, they ask you, am I going to pass on the corona if I have it? Dr. Tank, I'd like you to take this question. Dr. Tank is our gynecologist on the panel.
Thank you, Dr. Thakkar. And if there has been one bright spot of the corona pandemic really, it's the fact that there doesn't seem to be any mother-to-child transmission, neither have any teratogenic effects on the fetus being demonstrated. There is some immunological evidence that there may be some neonatal infection which might occur, but amniotic fluid, vaginal fluid, all that is virus free. So even though there are some case reports of neonates having been affected, as Dr. Vitlani pointed out earlier, the clinical picture is quite mild. They recover well, and there are no serious consequences. Breast milk also is virus free. So we encourage women that they should breastfeed, of course, taking all the hand and respiratory hygiene precautions.
So I think that was a good thing what you talked about amniotic fluid. I must go ahead and add that the semen has a very high content of the virus because the ACE2 receptor is very high in the cells of Leydig. So the semen also, thus making it one more sexually transmitted disease. So you have to be careful. The mask has to be everywhere if you don't want to pass it on. We have a great hepatopancreatobiliary surgeon with us, Dr. Indranil Mukherjee. He's also from the US. Dr. Mukherjee, thank you for patiently waiting your turn. We have he has a lovely wife, a pathologist, but I will come to the pathologist later. It's the man first and women last. You know, the best things are kept for the last. Everybody knows that. So I'm going to ask you, as a hepatopancreatobiliary surgeon, how do you go about in the management of your patients at hospital where you practice?
So I practice in New York and in one of the hospitals that is affiliated with a big health system, one of the biggest non-government health systems. So in the months of March and April, we did get the highest number of patients in New York and became the epicenter for the country.
Which hospital is this? Tell us a little more. We are keen to know.
So I work in Staten Island University Hospital. It's part of the Northwell Health System. So all the latest data with the highest numbers are actually coming from.
Can you speak a little loudly, please?
So I work at Staten Island University Hospital, which is a part of the Northwell Health System. And we got a huge number of patients. Each of these hospitals discharging approximately 1,000 plus patients.
Wow.
The hospital is almost a 600-bedded hospital and became an exclusively corona hospital because all our wards, ICUs were filled with COVID positive patients. The regular floors had been transformed to a ICU for all these corona patients.
So what we saw on CNN was true. Please tell us.
It was true. Means it didn't happen in our hospitals, but one of the earlier hospitals, the ambulance bays were full because they were taking so much longer just to offload these patients. But thankfully, with the social distancing, it did flatten the curve. I don't know if it will save life eventually, but did postpone the crisis so that we could um, be prepared better for this eventuality. Today, we know a lot more than what we knew in the beginning of March. And so we can tackle this problem much, much better with less panic and more information.
What you said about social distancing and expressed a doubt, I'll tell you a true story. If everybody in this world were to stand in one place for 6.5 minutes without moving and be more than 5 feet away from the neighbor, the virus would die. Everybody in this world has to stand still in one place at a 5 feet distance from his neighbor for 6.5 minutes, the virus will die. But gosh, that's not going to happen. I'm now going to go to your better half, who is a pathologist. And Dr. Jui, you must tell me that, I am also helping in the administration of a hospital here. And we found our pathology girls who were so shy to talk suddenly became very vocal and said, look, who's going to dispose of these samples? If amniotic fluid is infectious, what happens to the blood? Forget the other things. So can you give us a few tips of what you did in your hospitals?
Thank you so much for having us. Actually, hospitals and laboratories which have been managing large volume of samples, according to the CDC, they don't have to do anything extra for these samples. So if you're following the universal precautions, using hand hygiene, the PPE, decontamination of surfaces, then you really don't require any extra packaging for these samples. But also for places, if in case you are starting up, you are more anxious, then I think most importantly, a risk assessment has to be done on based on what tests will be done, what is the hazard of that test, the training of the people who are going to do it, and obviously the resources which are available. So depending on that, every hospital and lab will have to see what is best. But as of now, no extra precaution. If any sample is a source of infection, that has been believed previously and continues to be so. So you don't have to do anything extra for these samples.
Wow,
so
that's enlightening.
Yes, as usual. Yeah.
I'm going to pass this on. I'm going to come back to our senior most person on the panel today, Dr. A.B. Mehta. Dr. Mehta, I'm going to request you two things. One, to step up close to the mic and share your valued 6 decades or 5 decades of experience. Tell me, what will cardiology practice be in the next 6 months and probably in the years to come? What do you envisage?
Well, Hemant, before that, can I share with you a story a little bit?
Of course.
Yeah, okay, Hemant, what happened? Accidentally, I overheard a conversation between two friends. So, Nilesh, क्या करता है भाई? अभी कपड़ा धो के बैठा हूँ. अच्छा, तू क्या कर रहा है? अरे मैं पूछ रहा हूँ यार, भिंडी के शाक में हींग कितनी डालनी पड़ेगी? तेरे को मालूम है, आइडिया है क्या? And then नहीं, एक बात पर मी आता खाली जातो आहे, मैं नीचे जाके थोड़ा पान तमाकू लेके आऊँ क्या? अरे तेरे को कहाँ से पान तमाकू मिलेगा? अच्छा, ठीक है, गरम गरम चाय पी के फिर रात को पथारी बनाने का है, बेड बनाने के बाद में तेरे से बात करता हूँ. Alright, so now
men have become domesticated. I agree with you. That's why I won't blame all men, because they are going to store in the digital phone their wives' numbers as COVID-19.
Okay, yeah, that's a good thing. Well, I think first of all, for time to come, every patient who comes to me will have a differential diagnosis of COVID-related cardiac involvement. That will remain for some time. Therefore, when the patient comes, besides
a little loudly, please.
When the patient comes, and besides taking a good history and all, in addition to that, I will be a little reluctant to do an invasive treatment for some time more to come. A low-risk patient, I would continue to stick with thrombolysis and would not jump into an aggressive mode to put them onto the cath lab, because that would be an additional source where it could be potentially be he infected or the staff can get infected. 2, re-stratify very acutely that anterior wall myocardial infarction, patients having a drop in blood pressure, tachycardia, or those kind of cases where I anticipate in a little time you might go into a cardiogenic shock. On top of it, a patient who has come with a cardiac problem and hypotension, at the back of my mind, I will always have the aggravation of the cardiac symptoms by a COVID related pathology. And in that case, I would like to have from now onwards for some time more to come a teamwork. With me will be my physician, Dr. Hemant Thakkar, to help me to give a sort of a team approach to the patient. He will guide me about the COVID treatment, if at all there is positivity, but or also will also ask me to look into it in time to come during his ICU stay. So the pattern of practice will be a teamwork. I want to treat my cardiac patient with my physician, with shoulder to shoulder helping me. That would be the change in the practice that I would see.
That's it. That's it. Dr. Punjabi, I saw the glitter on your face, but I saw the white coat, and I think you're going to go off to work. So I'm going to grab your opinion once again. You've been a frontliner at the ER in New Jersey.
Yes.
Tell me, you know, I myself get bored because I have to change 3 outfits, have 4 showers, and we are all only seeing the pale blue and the white colors. All my colorful ties and the women's makeup and lipstick is all gone away. How much emotional and physical, mental trauma are ER physicians facing? You're at the front line. You tell us.
Yes, Dr. Thakkar, thank you. But just because there are a lot of non-physicians also watching this talk, I just want to quickly talk to you about a little bit, since I'm seeing a lot of patients every day face-to-face, how to wear the mask. I have a mask here in front of me. It's absolutely essential that when you wear your mask, it's covering your nose and your mouth. Do you see this very clearly now? It's covering your nose and your mouth, because the secretions, the COVID secretions can enter right through from your nose as well as from your mouth. So it's extremely essential that this entire part is covered. There are ophthalmologists here in the United States are also doing some studies now to see if the COVID virus is also spreading through the eyes. So actually in the ER, we are wearing goggles as well. And I just want to make sure that all my physicians and non-physician, the viewers are very aware of this kind of coverage. Now, to answer your other question, you know, when Dr. Makkar was talking about obesity, there's a hashtag of Facebook that comes to mind. It's called COVID carbs, right? Hashtag COVID carbs. It's a very real thing. I think we are so stressed from a lot of what we are seeing that we tend to reach for comfort foods a lot. And I think that's it's very real. And it is something that we all have to be aware. People who are in healthcare, people who are not in healthcare, to be very aware of eating healthy, good diet, because it's really affecting your metabolism and it's affecting your immunity. The 2 things that we are seeing very common that all COVID patients have that we've seen, one is in terms of risk factors, male sex and obesity. These are the 2 very common risk factors in all COVID patients who are very sick. Okay, so just
I think the network is bad out there.
Dr. Thakkar, can you just continue?
Yes, yes.
Dr. Thakkar, if you could pass on the question to someone else. And
okay, so the next question, sorry, I lost the audio for a minute. Is Dr. Vitlani there or she's left for the day? Okay, so if she's left for the day, she's left.
She's there.
She's there?
Yeah, Dr.
Dr. Vitlani, one last message to all the anxious mothers who want to put their children back into play school, nursery, etc. once the lockdown opens. Would you say wait? Would you say hang on? Would you say no? Would you say inoculation? What would you say?
I have one point observation in this last 2 months, that children who were falling sick so much, every morning we would be bombarded by 25 calls to see the children on priority basis, are no more calling us. That doesn't mean that they are not calling me because they don't want to come out of the house, but children are not sick, which also tells me that maybe there's a time to introspect by parents Maybe they are doing too much with their children at a very younger age, to put children into too early social activities of early, as young as 6 months, children go to toddler groups, they go to play activities, they go to closed areas for birthday parties. I think the introspection should be there that we should limit our children below the age of 3 years so that they develop their immunity. And I want parents to talk to their children about this COVID in a very open way, because children are very scared, especially 9, 10-year-old children. They have a lot of anxiety, and I'm getting a lot of frantic calls. So I think it's very important for parents to filter the media information. Please talk to the children and tell them that no, the whole world is helping. The scientists are working, the doctors are working. There's a lot of things happening good in the world. You don't have to worry, but yes, you have to wash your hands. You have to keep social distancing. You have to learn to wear masks. As she rightly said, Dr. Punjabi, that everybody should be taught to cover their nose and the mouth. Most parents themselves have their mask down when they're talking to me. And one important thing I want to tell everybody is about hand sanitizer. Parents are obsessed with hand sanitizer, and they pour almost 1/4 of the bottle in their children's hands when they are touching everywhere. And this hand sanitizer is high on alcohol content. They have to be supervised below the age of 6 years. And if their hands are not dry, they cannot eat or they cannot put fingers in their mouth. So I think at home, or as far as possible, they should be taught to wash their hands. And hand sanitizer, if to be used, to be supervised, especially below 6 years. And it's very important that children are counseled well, because children always personalize the incidents. They always feel death will come to me and my parents. They cannot take it openly. So I think it's very important to bring down their tension.
Great message. Since we talked about these 8, 9, 10-year-old people, I know that Dr. Banshi Sabu is doing a lot of work in type 1 diabetes. Dr. Sabu, COVID and type 1 diabetes, any message, any correlation? Because you have a lot of COVID patients, and I mean, a lot of type 1 patients. You have a message for that?
There are 2-3 issues with type 1 children particularly. As Dr. Vitlani was talking, that type young children are spared. That's right. But those who are uncontrolled diabetes, and even they are young one, but still if they get infected, there is a possibility of slightly increased morbidity. We don't have any data for as far as increasing mortality, because there is a paper which was recently published by International Society of Pediatric Diabetes, spared. There is no increased mortality, but definitely they are at more risk of developing more infection. Once they get the infection, they get more morbidity. The second big problem is we don't know about the systemic inflammation which they develop post-COVID, like the Kawasaki disease. We don't know after 2 months, 3 months, or maybe after 6 months, there may be possibility of increase in type 1 incidence, as it is also related with autoimmune or inflammation. So because most of the type 1 diabetes, if you just see their when they develop diabetes, before few months, they have a history of some viral infection. So autoantibody induced inflammation may be the cause for their beta cell dysfunction or beta cell destruction. So we will know about this after 3 months or 6 months. The third issue is the type 1, because of this lockdown situation, there were conditions where people were not able to get their insulin supply or the glucose meter supply. So we got slightly increased incidence of diabetes ketoacidosis and few more incidents of hypoglycemia also. So few of my calls were there related to either their uncontrolled diabetes or maybe because of hypoglycemia, and they don't have the glucose strips or insulin supply. So what we have done through RSSDI nationally, we have, the helpline number was given to all in the social media also, and all our patients, to those who are not getting the supply, they can contact this helpline number. So in last almost 60 days, 45 to 60 days, they could get at least supply at their home also. So these were 2-3 major issues with the type 1 children. Thank you.
Very nice. I also see a few type 1 and they are never quitters. So they prove the point that quitters never win and winners never quit. These young kids, since they are challenged right from a young age, they really grow up into solid, nice manifestations of humanity. Dr. Chaudhary, we are seeing gastro and loose motions presenting in COVID. So, Dr. Gurdras Chaudhary, you think that this gastroenteritis and GI manifestations, when we come across them, people are going to first think of COVID and then of all the remaining things? How are you going to tackle all this?
Difficult. I would say that, just presenting with loose motions may not really arouse our suspicion to the extent that we become paranoid. But yes, if a person has fever and has got a sore throat and thereafter he gets loose motion, certainly yes. But on COVID, there is never a last word right now because none of us know. It's after all something new. But since you gave me the chance, I just want to make 2 points, if I may. One is that, there is a international catalog which is listing the number of doctors and healthcare workers who have been infected with COVID and who have died. I hope all of you are following that. There was one list of 100 doctors from Italy, and now all over the world we know that. Interestingly, when I was looking at it, the major share of the doctors who got infected were ER people, ENT people, so Dr. Chaturvedi is there, dentists, chest specialists, and gastroenterologists.
Look at that.
So let me tell you why the role of gastroenterologist has become important. We are very fond of doing procedures by putting tubes down. I mean, either through the mouth or from the other side. And these tubes usually have an air channel, and it generates something called an aerosol. And it has been found that doing a procedure on a COVID patient whom you did not know, could have been an asymptomatic carrier, produces a tremendous amount of virus spinning around in the aerosol in the room. And that is a potential cause for infecting others. In fact, if you look at the hospital-based outbreaks of healthcare workers, it has primarily occurred in the surgical suites. I wish our 2 surgeons also comment on it because, laparoscopic surgery is associated with a very high amount of aerosol generation. And so is endoscopy and colonoscopy. So I thought that that's a message which
brilliant.
Probably the doctors would like to carry.
Dr. Punjabi will agree with me that in our medical conditions, we have stopped using nebulizers. We put the patient on inhalers or rota caps because nebulization is a very important source of aerosol generated virus excursion. Plus all our new ICUs, which we've converted, we've started having negative suction. So everything goes unidirectional. Dr. Chaturvedi, you are ENT, you are likely to get this aerosol-induced problems. So either you tell us the fear that you might have of it, or you lighten our mood. Dr. Chaturvedi, I want you back.
Yes, sir. So, no, definitely, sir. I think, like sir has mentioned, we've also stopped a lot of our, because I am a nose and sinus surgeon, so really a very high viral load area. So where we are involved sometimes to take a nasopharyngeal swab, I think most of the other things we've temporarily stopped, and most of them are always in the elective space, except for nose bleeding. But on the lighter note, just to keep that going, I can share a couple more incidences which have a social message, but which we have got, which are also towards the lighter side. Is one day we got a call from a patient who's extremely breathless, and he's saying, I have COVID, I have corona, I have COVID, I'm breathless. But as we kept talking to the person on the phone, the breathlessness went away. So I asked, what were you doing before this? And why do you think you have corona? So he said, हमने किसी बाबा जी को देखा था that if we hold our breath for 1 minute and we cannot do that successfully, we have corona. And I was trying that and becoming breathless because of it. So a lot of people also question that, is holding breath for 1 minute a cure for corona? One other distressed lady, she called and she said, my husband is drinking a lot of alcohol. And we were like, yes, we will help you, ma'am. We will direct you to the right people. She's like, no, the concern is he also wants me to drink alcohol because he believes by drinking alcohol, it will wash away the corona. And he wants my kids also to have alcohol because we wash our hands with alcohol. And if we drink it, it will go away. And then I really had to take time to, counsel and say that there's a very different percentage of alcohol that kills the surface. And if you drink that, it's going to burn everything. So this has got nothing to do with that. And there's a lot of disinformation floating around, sir, which is also goes hand in hand. And sometimes is more dangerous than just what corona can do is the misinformation, and to the extent that people take interpreting these.
Thank you. You talked about alcohol. I can see Dr. Henry Colt. It's early in the morning from him. He's grabbing his second cup of coffee, but before he goes away, Dr. Colt, I know you've been doing some research in COVID. So I'm going to open a little window and peek into your mind and tell me about this little research that you are doing. It may be big news.
That's correct. One of the global research projects we have done is a case control study of transmission of COVID to healthcare workers. And we're looking at some of the data right now and have certainly found, I think one of the most important findings is that personal protective equipment does work. And therefore, if the physicians, the nurses, the hospital systems provide the adequate, the satisfactory personal protective equipment to their staff, we should be able to proceed with routine diagnostic examinations of our patients. I think that's probably the most important thing. This has been a systems disaster, and it is up to our regulatory officers and administrators and governments to provide the correct protective equipment to the healthcare providers. And then we need for those healthcare providers to wear the equipment correctly and to be very careful when putting on the equipment and removing the equipment to not auto-contaminate themselves.
Great, great. Dr. Arun Shah, you're my go-to non-COVID panelist. I want you to give a nice, loud and clear message to all those neurology patients. They may be epileptics, they may be paralytics, hemiplegics, quadriplegics, they may be neuralgic, they may be all sorts of people. How are they going to cope with their issues and their neurologists in the next 3 to 6 months? Can you tell us? Unmute yourself, please.
Yeah, Ahmed, thanks for asking this question. I think it's very important that what we learned in last 5 weeks of COVID pandemic and lockdown, this video consultation solves quite a lot of problems. So in neurology particular, many follow-ups of Parkinson's patients, epilepsy patients, and some neurologic patients, I'm sure we can manage with video consultation even in future. But there are certain illnesses which we'll have to go back to our OPD to see, because every patient of neurology cannot be managed on video consultation, and that will require probably, as Dr. Cole has just mentioned, that if we do PPE and start seeing such patients after we decided from video consultation screening that the person requires personal visit, we'll probably do. I want to tell everybody that neurologists care can be taken very well in acute stroke patients who have early symptoms. Do not feel shy of going to the hospital. Probably going to the hospital will save them from a major stroke, and that is possible. Every ER department has definite separation of triage areas, and by going to the ER department, you are not going to catch COVID infection. That everybody must remember that, and without fear, go to the ER department if you require help.
I think it's a beautiful message. COVID may come and COVID may go, but routine neurology will go on forever. And thank you for that message, Dr. Makkar. You talked about obese people and their problems with COVID. I want to know about those people who have become obese sitting at home for 2 months. And I want to know what message you have for the next 3 months for both kinds, the pre-existing obese and the newly developed obese, because some of them, as the cartoon show, they won't be able to get out of the house because they've put on so much weight, which is why there's a huge queue for the liquor permits. Dr. Makkar, the floor is yours.
So, very good question, Hemant. As you know, Dr. Kutum Punjabi also mentioned that the highest number of patients who had mortality were obese and men. So, most important thing is, one, if you are obese, do not gain more weight. That is most important. Continue with your regular exercise plan, sustain a healthy diet plan, maintain good, food intake, good hydration, take sufficient greens and fruits so that you have good immunity, take high protein diets rather than, munching on carbs, cut down all the nonsensical eating, keep measuring your weight every morning. Just keep check on your weight and be very good with physical activity. See, every time when an obese patient walks into clinic, we tell them to go for exercise. They tell us, sir, I don't have time. Now, this is the time you have all the time on this earth to perform good physical activity and maintain good health. People who are not obese should again follow a good, healthy lifestyle, maintain at least 1 hour of good physical activity, healthy eating. Try to build up your immunity so that you can fight with COVID. Once you get COVID, not everything is in your hand. But if you have good immunity, you will certainly fare well with the ward with COVID.
I think it's a great message. Though I must share, being a metabolic physician myself, I'm seeing a lot of patients at home doing well also because A, they are eating home cooked food. So all that fast food, burgers, KP choy, everything has gone.
But
Did I say
what another thing that I'm seeing is that on every WhatsApp group, everybody is posting, I cooked this, exotic dish today. So somebody is making chola bhaturas and somebody is making burgers. So even if they're not getting food from outside, they're cooking that, high cal, high carb food at home and kind of indulging in eating. So that has to be curtailed.
You're absolutely right. There are two kinds of people at home. One that sees the moment to eat, and the other sees the moment to make it a memory, a memorable moment, where they are keen to see that the time that they have, that they are doing everything that they could not do, that is walking, that is reading, that is meditating. And I think that's the message that I want to give. But I have Dr. Dalvi, who is our surgeon, is a man who also helps the administration and the Surgeons Association make certain norms and rules. So I'd like to learn from Dr. Dalvi what is on his plate for the next few months. Dr. Dalvi?
Yeah. Since you have talked about guidelines, I am the Vice President of the Association of Surgeons of India, will take over as President 21. There is a lot of roles of associations which come into picture in suggesting to the government of India regarding formulation of guidelines. And let me really praise the central government that almost every day guidelines are coming up with modifications, as this is a very dynamic sort of thing that is happening. So it will take a lot of time to tell me about guidelines. So please visit the Ministry of Health website and read the guidelines for yourself. The last ones that have come up is just day before yesterday. And a detailed thing has been given as to what you are supposed to wear in OPD, in triage area, when you are operating, what is the attire that a healthcare worker, including the sisters and the sweepers, etc., are supposed to wear. Having said that, let me also see the future as the lockdowns, etc., go down and the coronavirus fear also starts going down. As I was saying earlier, there are 3 types of institutions that a surgeon is attached to. One is a small nursing home setup with a single theater avenue. 70% of the healthcare setup is out here. The next 2 are the institutional setups, which are in private and public. Fortunately or unfortunately, I've been associated with all these 3. And what I see for small nursing home setup is a huge challenge to convert their place into a place where a COVID positive patient could be treated. More so in the post-operative period, if this patient turns out to be positive. I know of instances where the entire nursing homes in Karnataka have been sealed by the authorities. So it's going to be a huge challenge. And these sort of people have to be geared up for changes in their infrastructure, or say nicely that I'm going to refer this patient out. Hopefully, as you rightly said, we will get these tests which will tell us results in 3 to 4 hours. And there you go, the patient can be transferred. As far as institutional setups are concerned, the private institutional setup usually have a single OT block or 2 OT blocks on separate floors. People with 2 OT blocks on separate floors are at a distinct advantage, where the COVID patients, positive patients, could be operated on one floor, which is designated, with a floor designated to harbor or hold these COVID positive patients. But those who have OT complexes in a single floor or single complex, they are going to have to change somewhere down the line. Institutional public setups are the one where we cater to a lot of patients and we have to be on guard. And that is where I would suggest strict guideline measures have to be put. somebody in the had said about donning and doffing. In a single nursing home setup, you have hardly any area to don and doff a PPE that you are wearing. But in public setup also, lot of changes are going to be required to actually educate the class 3, class 4 workers as to what is donning, what is doffing, etc., etc. So I hope you understand, as a surgeon, a lot of things are in addition to physicians who are actively involved in COVID treatment. A lot of rearrangements will have to be made.
Great.
I just saw on a chat, as I conclude, some message for the common man. If a surgical patient comes to me, I can only say that I am as common as you are. Trust me, whatever I advise, whether to postpone surgery or emergency surgery, I am with you as a common man. Please believe in me. The trust which is slowly going away between the patient and the doctors. Thank you. Thank you, Hemant.
Thank you. Thank you for saying this, but I must re-emphasize the trust is not going away. We are the white warriors. We are currently being worshipped. When that will evaporate, I don't know. I was going to actually go to the gynecologist, but since you stoked the flame of hospitals and institutions, I thought, you know, everybody in Bombay who falls symptomatic or thinks is symptomatic wants to go to emergency room. Dr. Punjabi, you've been manning the emergency room for a while. Can you tell me who should come and who should not come to emergency room? Do you have some guidelines?
Sure. Dr. Tucker, thank you so much for asking this question. I just want to make sure people know, a lot of the different speakers here today have said this. If you're having stroke symptoms, right, where you get facial droop, difficulty speaking, part of the body gets paralyzed, please go to the nearest emergency room. If your abdomen hurts, right, you're vomiting, or rectally you're removing blood from your rectum, please go to the emergency room. If you feel left-sided chest pain, or you're starting to sweat profusely, please go to the emergency room. I know everybody's really afraid of the COVID infection, and I think there are a lot of reasons of not going to the ER and calling your doctor and getting a consultation on the phone. But there are some very big guidelines of real severe pain and real severe symptoms I really don't want people to ignore. You know, that has been a problem here in the United States. I'm sure the other doctors in the US can tell you. We've had lots of patients who did not come to the ER. I had a patient with severe cancer on chemotherapy, you know, ovarian cancer on chemotherapy, who started bleeding rectally, and she wouldn't come to the ER to get seen. And, you know, she ended up coding and dying in her house. And that is not what we want. You know, we are all taking full precautions. And in fact, now, because we've been 2 months out in the United States with the disease, it's called COVID fatigue, you know, for physicians. Where when I'm putting on my mask, my goggles, my gloves, my hat, my gown, when I go to see the 4th, 5th, 6th patient, I'm forgetting to do the right equipment. So we have a buddy system now where a person is watching you don on, wear everything, and watching you dob off, just so that you don't forget for the next patient to wear the goggles or to wear the mask. So we actually have a buddy system to make sure before we enter a COVID patient's room, we wear that. Also, I want the common man to know we are assuming everybody is COVID positive. So we are taking full precautions no matter who we are seeing, when we are seeing. So if you are sick, please go to the emergency room to be seen. If you're not sick, make sure you call your doctor and get the right advice about whether to go or not to go.
Thank you. Thank you very much. You mentioned buddy system. I'm going to go to the gynecologist. You know, everybody is saying that this is the time when physicians are ruling the roost and they have all the numbers. But I know that, like Dr. Makkar said, people sit at home and eat. And the others said people sit at home and just drool and meditate and depress. I know that 8 months or 9 months from now, Dr. Tank is going to be extremely busy because people are busy with XXX and the population baby boom explosion is going to come after 8-9 months. So as a gynecologist, what are you planning to do in December and January, Dr. Tank, and any advice to the patients?
Thanks, Dr. Thakkar. For one thing, I'm not going to take a vacation in December and January for sure. But I think the baby boom is probably more of a popular myth. We have to accept that most people who are not interested in having children, in India at least, use tubal ligation or an intrauterine device. So that's already in place, and that's not going to get affected in terms of availability by the pandemic. Uh, Fortunately, chemists are also open, so oral contraceptives, condoms are also available. And the fact is that for people who don't want a pregnancy which might have occurred, there are services of terminating a pregnancy which are running in most public and private hospitals. So even though one might like to believe that there is going to be a baby boom, I seriously have doubts about that.
Dr. Tak, you have made a very slippery topic, very clinical. I want somebody who puts a little fun into it. Dr. Vaya, where are you? Dr. Vaya, you can tell us about what we shouldn't do at home, from food to fun. So let's have your take on this, because it's the mind that rules the body. Dr. Vaya.
Thank you, Dr. Thakkar. I have heard many people saying social distancing. That's a misnomer. What we need is physical distancing with increased socializing. There should be increased virtual socializing. Talk to people, talk to your friends. That helps. We need to ventilate our feelings. Today, doctors are considered to be the source of authentic information. So people will phone you up. People don't like to phone up a psychiatrist because they don't think they are mad, but they need reassurance. So they would phone up other physicians. When that happens, avoid giving a knee-jerk advice. Most of the time when the patients call up, they just want to ventilate. They don't want an advice. They just want to ventilate their feeling. About the physician taking care of themselves, please make sure that you have my time. Half an hour, 40 minutes, when you switch off your phones and switch off your contacts and just be with your own self. That brings us to the importance of Corona time. Please restrict TV news watching time. And as far as possible, avoid watching those debates with their own small hidden agenda. It's important to talk to people, and there is happiness through kindness. So be kind to yourself and be kind to your people and even be kind to strangers. There is happiness in kindness, and there is importance of ventilating because there is increased incidence of domestic violence and suicides in people who bottle their own emotions and anger. It's completely normal to feel anxious and depressed, but there's a solution not in medicines but in good communication with people who you trust. Thank you.
Great, thank you. I have the lovely couple from US that are going to bring it the tail end of everything. I'm going to go to Dr. Jui first, ladies first. Do you want to tell us something about convalescent plasma? You are a pathologist. Everybody wants to go and collect plasma and inject it in everybody else. Do you have a message for that?
Yes, so convalescent plasma has been used previously for other infections. And what is it? It's actually plasma from somebody who's recovered, has developed the antibodies. Sorry, you'll have to excuse our
No. We can see that the baby boom is still round the corner.
Okay, so the convalescent plasma is then it's antibodies which is recovered from somebody who's recovered previously and then given to somebody who's severely ill. I want to emphasize that at this point, it is on trial basis in many countries and is being used for the most severely ill, because at this point, we're still not sure what's the amount, the frequency, and how safe, like how effective is the process. But China does have a few studies which have shown that they gave it to a few patients, they recovered, and there were no major side effects. So we'll have to wait and watch for that.
Great. Before your husband can come back, we have Dr. Chaturvedi. Oh, lovely. Would you like to say a few words before a message from you from the East Coast to tell us about the surgical point of view, something you need to tell us?
I think from the surgical point of view, Dr. Dalvi did, and everybody in the panel did give us a lot of input. The only thing I would like to add was that during this last 2 months, all the surgeons and the physicians have become used to using the telemedicine. So we started to initiate telemedicine from the beginning of March. So the number of patients' visits have been reduced because we can do most of these things on telemedicine. Plus, inform them about the right etiquettes and what protocols that we have initiated so that we can bring back the confidence in patients so that they can easily access their healthcare. We have also started to educate the patients once they come here, what are the protocols that have been in place to protect them and the staff. We are right now doing some emergency surgeries, and we are informing the patients that depending on the severity of the illness, we might be able to do some not so emergent, but some elective, but high priority cases, and how they rank in that priority, what are the steps, including the coronavirus COVID testing before the surgery, which part of the hospital they would be staying in, which the second operating room, which is supposedly disinfected and corona-free, with staff that have been well trained and equipped with fitted N95 mask. I have seen a lot of people in US and in India wear a regular N95 mask, but we are getting even our non-clinical staff with fitted N95 masks.
Thank you. Thank you. Dr. Chaturvedi, one last bit from you before we sign off and thank everybody.
Sure,
I have a
sir.
message after that.
Sure, sir. So in addition to comedy, which we've used, I've also used some rap songs to get some awareness across. I've shared a link of how to wear and remove a PPE suit using a rap song in English.
Do it quickly for us. I'll give you 2 minutes.
Yes, sir. I won't do this one. It's too complicated. I'll do one more, which I sang with Baba Saigal. I'll do a small paragraph of that to make aware people. It's called Michael Ki Mona, and my paragraph was, सब्जी लाओ तो हाथ धोना, ताता थैया करे कोरोना, खा ले घर में रोल काठी, बाहर पड़ेगी पुलिस की लाठी, मास्क नहीं है रुमाल ले ले, चिकन नहीं है दाल ले ले, फोन बजा है ट्रिंग ट्रिंग, चल गर्लफ्रेंड की कॉल ले ले. So it has a Baba Saigal touch to it, but it's a song tried to bring awareness. The PPE song is a bit technical. I don't remember the lyrics, but we read the guidelines and we put that across.
Thank you.
And we put another song on quarantine. But on a lighter note, I would like to say that my practice has been benefited by telemedicine because my name Jagdish Chaturvedi sounds like a very elderly person. But when people come to my OPD, they look at my baby face and they generally ask, Dr. Chaturvedi kidhar hai? And when I say I am Dr. Chaturvedi, they look at the nurse and they're like, sister, Dr. Chaturvedi ke room mein Varun Gandhi kya kar raha hai? Because I have that Varun Gandhi look. But now what I do is I put a little older photo of mine and do some teleconsultation. But with that, I hope the humor continues. And thank you once again for having me on this talk.
Ladies and gentlemen, this ET virtual classroom has shown us that success finally comes as a good fortune to those people who practice aspiration, perspiration, desperation, and inspiration. We are in desperate times. We need that success. It is knocking on our doors. And we all know that the effort is not going to be single-minded. The world is a global basket. It is the blood, toil, sweat, and tears from everybody around the world, including Chinese chop suey, that is finally going to produce some remedy. I might share to a few people who, if you haven't heard, about 2 hours ago, there was an announcement that BAT, not BAT, but British American Tobacco Company, have finalized the new vaccine and they are starting human trials next week. So that's a silver lining to the gray cloud. I want to thank MedWiz for organizing this. I want to thank ET for this new normal. The normal is not what is going to be defined. The normal is what we are going to write. And all my panelists have been so experienced, so senior, they're going to help us to write the normal. And we will make the normal. Thank you all the panelists. Thank you, ET. Thank you, MedWiz. And most important, thank you, viewers who have taken the time. If you have questions, send them to us and we'll write back to you independently. Thank you. I'm socially distancing. Have a great evening, all of you, and the rest of America.
Thank you, Dr. Thakur. Thank you, panelists. Thank you, all the delegates. It's a real pleasure to have you all across, share your views, experiences, and like what you rightly said is, Never ever had the scientific community in the globe had united so well that we had real-time sharing of information. 2 hours ago, British company starts a vaccine and we are talking about it. That's rightly, aptly said, one world, one problem. That is why we all come together to sort it across. If we are united across the globe, I don't see an agile community or agile species like human being why we should not be able to solve it. Thank you so much for all your time, everything, Dr. Hyman Tucker, for beautifully moderating and getting across faculty from this. I just want to have a closing note. We had people logging in, more than 25, 30,000 people seeing this live. We had people from Myanmar, Africa, India, US, all of it. And we're going to put across this link again on YouTube, recast it again for people to take it across. Thanks a lot for your time. I mean, it was more than the number. We were actually prepared for 5 to 10,000 people seeing it, but the numbers crossing 25,000 is something that we're very happy.
Stay safe,
Great.
everybody, until the antibodies come positive. One day they will. You, me, and everybody else. God bless.
Thank you so much. Signing off from Medwiz and Economic Times. Thank you so much. Thanks.
Bye.
Bye. Have a
Thank you.
evening and great morning. Thanks. Bye.
That's